Hi there, everybody. Today we'll be going over the overhead squat test and some common malfunctions you can see within the test itself. So for my specific case that I had for class, it was case 15, where the patient was instructed to do a overhead squat, the test, and they would stand with their feet shoulder width apart, and then toes pointed straight ahead, arms raised above the head, and they were asked to squat down as if they were sitting in a chair. And with this specific patient, the faulty movement patterns that were identified would be that they had flattening of the medial longitudinal arch. Some potential underactive muscles that we want to address, that was kind of the second portion of this assignment. I thought there would be a weak or underactive tibialis posterior. First of all, I think that would be kind of the main muscle to target right away. And then anterior tibialis would be underactive. You want to look at their dorsiflexion or how much they're able to get. And then finally, more so up the chain at the hips would be gluteus medius and gluteus maximus to see if they're allowing their foot to, or their whole leg essentially, to internally rotate, which would collapse the arch. So with Becca here, I'm just going to demonstrate what the test will look like. So I would have my patient, just for the sake of this video, should be on the table here. The shoulder width apart for the feet, good. Feet straight forward, and then I'd go ahead and have her raise her arms above her head with a post.
I could have moved it. I'm sorry.
But imagine she's having a pole in her arms there. And go ahead and instruct her to squat as if she's sitting in a chair. Okay, good. And with this patient, you would see collapsing of. Thank you. You would see collapsing of her medial longitudinal arch if she had those weak structures. And so then some problem areas that you might see with a patient with this problem would be internal rotation stressors at the ankle, knee, and hip joints. So as you have the ankle mortise, as it goes into internal rotation, collapses down, the tibia is going to internally rotate, knees going to internally rotate, and then the hip could potentially also, over time, internally rotate, just causing stresses on the external rotators. Could be elongated, could be weakened. Like the flat arch, like I said, it could lead to plantar fasciitis, things like that. And just the internal structure integrity of the ankle joint would be compromised. Excessive foot pronation has been found to increase anterior pelvic tilt. So I did a little research, found this article that said that with excessive foot pronation, as I said, would increase anterior pelvic tilt over time by at least 20 to 30% in standing and 50 to 70% while walking. So essentially what the article talks about is a falling of the arch could lead to the anterior pelvic tilt, which could lead to lumbar or excessive lumbar lordosis, and then further into low back pain. So with our low back pain patients, that might be something that you can consider, is if they have a fallen arch. And then some corrective exercises that we'll go through. First of all, just a standing calf stretch, just to get the tight structures in the back, or at least to get improvements in your dorsiflexion before you start strengthening the muscles that would raise the arch. So for the standing calf stretch, I'm going to have Becca, let's see, right here. She's going to go ahead and use the wall here. And what she's going to do, so say we're working on the left foot, she's going to put her left leg into full extension and then push into the wall with her upper extremities. And as she's going further with her hips forward, I want her to squeeze her glute here to get that little bit more external rotation and increase the dorsiflexion. So we're going to have her hold this for 20 seconds at a time, 3 times per set, and then go ahead and relax. So I'd start with that, first of all, and then
Such a bad kid.
And then for the second one that we would go to would be a resisted ankle or anterior tibialis activation. So I have my patient long sitting on the table.
Perfect.
And we're doing activation of the anterior tibialis. So it's essentially just applying resistance to the forefoot and having her bring her toes up to her shin. And hold that and back down. Again, I can have her do sets of about 10 or so, making sure that she holds it at the end range, and then slowly coming back down with the eccentric load at the end. And then also we have posterior tibialis strengthening. which would be a plantar flexion and inversion. So I'd bring the foot in this position. I'm applying resistance this way. She's going to go plantar flex and invert the foot at the end. So you're going to come plantar flexion and inversion, just like that. Yep. And then another way that you could strengthen the posterior tibialis is if you have her do a single leg calf raise. And then finally, a more functional exercise, I guess, would be standing squat ankle stabilization. And this is kind of, I got this offline. It looked pretty interesting, so we thought we'd give it a try. What she's going to do is hold on to a resistive band with her opposite hand of the leg she's being stabilized, or we're working on. So we're going to say it's your right leg, so go ahead and stand your right leg back up. Take this with your left arm, and what you're going to do is you're going to go back into a squat.
A lunge?
Or a lunge, I'm sorry. And then come up out of that and onto one foot. And then hold that. And back. And then back up towards me. Good. And this would be progressive, beginning with some assistance, and then hopefully move out of it so she could be able to do it without the resistance or the assistance band. And then some assessment outcome measures that we want to take would be dorsiflexion active range of motion, passive range of motion, and then we'd also look at the navicular drop test measured while she's doing the FMS squat. Thank you for watching.